We're joined by a chairman of one of the very vital institutions in the country, the National Health Insurance Fund, NHIF. Engineer Michael Kamau is the chairman. Good morning, sir.
Good morning, good morning. Happy to be here.
Karibu sana.
Asante.
And the last time you were here, you were not the chairman of NHIF. Now that you are, congratulations. It's been how long?
Sana.
6 months.
Sana. Yeah, 6 months. Going to 6 months.
6 months in office.
Yes.
Now you know the lay of the land. You understand everything that's happening in that particular organization. And you know the entire dream of universal health coverage.
I do.
That's what we'll be discussing.
Thank you.
And to understand the institution.
I'm ready.
CT has been giving us proverbs from Zambia the whole of this week.
Yes.
And today's proverb is a story.
It is a story. A very brief story, but it's a story that's laden with meaning. Mother, carry me. I will carry you too. That's a proverb from Zambia.
Mother, carry me. I will carry you too.
At a later date.
Yeah.
In old age. That's it.
You think that's what they meant?
And that sounds like it's meant for NHIF.
Ah.
Yeah, the young pay. They don't get sick. And they support the old. Yeah. Those who have pay to support those who don't have. That's the whole essence of insurance.
It's the whole
We
essence.
pool resources.
Engineer Kamau, you've been contributing to NHIF for very many years,
Yes.
right? Several decades.
Yes.
Now you're the helm of this institution.
4 decades.
You're at the helm of this thing that how you just every month money just goes. Your payslip reads NHIF, NHIF, NHIF.
Yes.
Now you can understand it, all right? But let's just begin with what's currently happening in the country. It's been in the news, NHIF,
Yes.
especially with your service providers,
Yes.
not being able to offer the services that NHIF should be covering.
Yes.
And then the other day we saw the health CS talking about the disbursement of some funds from the National Treasury to the NHIF, and now that is going to sort out the issue. Please explain what's been the issue.
Basically, we receive our contributions from individuals. Yourself, I'm sure you contribute to
Yes.
NHIF.
Yes.
Then we have both in the formal and informal. The informal, it's voluntary. Those who are in the formal sector, it's a check-off system. So you pay. You are not asked. It's law. And then we have government schemes. Okay? We have Leader Mama for,
Maternity.
Maternity. We have Eduafia for all students in public schools. We have enhanced schemes for civil servants and certain groups of people who pay additional premiums to get these services.
Yes.
Now, the money we were receiving from government, the one that we received, about 12.2 billion, is for those government schemes. The government had delayed in paying premiums. And because we pool all our resources, it meant that the only money that was basically coming is those of the formal sector and the voluntary contributions by the informal sector, and that's what we are now using to disburse. And therefore, for a period of about 3 months, we fell behind in payment to our service providers, and it was a real problem. However, we received money on Monday, 12 billion plus, and we have disbursed all that money today. So, as I talk, we don't have anybody we owe in the cash office at headquarters, all the claims that had come. But before we would have a balance, and every month, and it was accumulating. And you can imagine if we have received 12 billion and disbursed it, it means there was a big hole.
There was a big hole.
Very big hole.
In your cash office.
Yeah.
How much do you spend per month in paying all your signed up health providers?
About 4.5 billion, 5 going to 5 billion.
4.5 every month.
Every month.
And how much do you receive in contributions every month from
Contributions we receive to the tune of about 3.5 going to 4 billion. Yeah.
So what do you do to bridge that gap every month?
We do campaigns. Basically, we campaign so that we receive more premiums. Like right now, our people are out there trying to get people in the informal sector, and also compliance of the formal sector For example, the compliance in the formal sector is in the tune of about 77%. So you find there are people who are not remitting, even government. When you hear that there are some institutions that have delayed salaries
Yes.
for
their workers,
for their, I don't want to mention, public institutions, it means those deductions are not coming. Or when you hear that there are institutions that are paying 50% salary to their staff, they make the statutory deductions from your pay slip,
yeah,
but actually don't remit.
they're not remitting to NHIF.
The same way they fail sometimes to remit to KRA.
Yeah.
So those are the people now we pursue within the public, within the formal sector. Then you find also people who want to run two payrolls. You know, one, if you have 100 workers, you have one where you are paying NHIF so that it is visible. So basically what is happening is that we are combining forces with KRA to make sure that if you are paying payee, then the NHIF payment should also be there. So that's going to help us.
Looking at all the contributors now, that number that you've given, like, so what you collect of 3.5 billion, what is needed in terms of cost per month, and then looking at these campaigns, let's look at a situation whereby everybody who is currently signed up on the grid, as it were, is paying. Would that be enough?
If we went to, well, one of the biggest problems is this, and this is where our problem comes in. The people in the informal sector, it's voluntary, and therefore people only come when they are sick. Okay? So, like we've seen, we have charts that show that a mother who is pregnant will only start paying NHIF maybe on her 6 months of pregnancy.
Yeah.
Okay? So she is able to deliver, you pay 1,500, and then you are through with your delivery, it's paid, and that's okay. You are diagnosed with cancer, it could be stage 1, and then you know you are going to need treatment.
Yeah.
Okay, so you start paying.
2
months down the line, the cancer will not have killed you, and then you start on a regime of treatment. So that is our biggest problem. And the payout to the informal sector actually goes up to 230, almost 2.5 times their premiums.
Wow. So how much you're collecting from them?
If we collect,
and
say,
how
a
much
billion,
you actually
the
pay
payout is like 3 billion. So that is the biggest problem that we are having because it is voluntary.
Yes.
However, when we go to the now the social health insurance scheme, it makes it compulsory for everybody, such that whether you are sick, as long as you are above the age of 18, you should be contributing from when you can get your ID.
Your ID.
Now that means we would have a lot of resources to pool, and then we would be able to treat everybody.
Are you able to tell from the formal sector, the way you've talked about it, and the informal sector, which then comes to seek medical care more than the other? Is there something like that?
It is the informal sector.
It's the informal
It's
sector.
the informal sector because you can imagine a guy who is 18 who has just been employed and is on a payroll. People below the age of 40, you don't have any health problems. Okay?
Major health problems.
Major health problems. You know, it's a cough, it's a flu, but surgeries like, by the time you get to 55, even for women, that's when you start to have issues with breast cancer, with prostate cancer for men, hypertension kicks in, then, the chronic diseases, then you have developed some diabetes. When you are young, you are just paying and we are using your money. You don't. In fact, we pride ourselves when we are young that I've never gone to see a doctor for 5 years and so on. So, but there is nothing to incentivize the people in the private sector if you are, say, 21, to pay for NHIF. What for?
So then wouldn't that be where the focus for these campaigns that you speak of then targeting? Because we've seen, like you said, people in the formal sector, if it's maternity, women start to pay 6 months into pregnancy, right?
Yeah.
People then come and they get looking for they obviously they do get high payouts for medical care and treatment. So they see the direct benefit
Yes.
of having the card,
Yeah.
of making the payment. Because look, I went to hospital, I paid nominal, and it could be for opening a card, for
Yeah.
example. But you could have life-saving treatment, surgery, and then after care, and you pay nothing because of the contributions that you've made.
Yes.
So you see the direct benefit. Shouldn't then the informal sector be the target for these campaigns to getting more people on the grid?
Exactly. And right now we've mounted a campaign in the board where we are going around and doing campaigns in markets and trying to get people in the informal sector to register. Because basically also the people in the informal sector, one of the biggest problems, what we call the WhatsApp group. I'm sure all of you will be in a WhatsApp group that is asking, if you opened your phone, somebody is asking for contributions, okay?
Yep.
So that is the kind of campaign that we are carrying out, that if you don't want to get into these groups, even when we go back to our rural homes, encourage people to pay. Now, let's look at it, forget sickness. Anybody who is on a motorbike is a candidate for
Hospitalization.
Yeah, hospitalization, broken
Something.
limbs. Yeah. And therefore, I tell people, please, even myself, I use motorbikes. Okay? The moment you bought a motorbike, you are likely to have, if you use them for 1, 2, 3, 4 months, and I'm not saying everybody who has used them for 1 year, but we know that in our hospitals, there are very many people who have suffered injuries. So it's like a cover. This thing can come from anywhere, a road accident. So it's not only sickness. No, it's even accidents at home and anywhere. Your cow can knock you down. You can fall down in your bathroom. So we should cover everything.
Basically, just be prepared, because you never know when you will need.
And for example, if I may give you an example, the people who are on dialysis, do you know that we pay for dialysis at a rate of 9,600? So you find you have a kidney problem, okay, and you need dialysis, and you need 2 sessions. We pay about, call it 20,000 for ease of arithmetic, and at the end of the year, if you are going to continue with this dialysis, it's about 1 million bob, and you only have contributed 6,000. So you can see what I'm talking about.
Yeah.
And you to continue for maybe 3 years until you get somebody who can give you an organ, so that you can go for transplant. The big argument is now that because we are not able to sponsor for transplant, is whether we should spend 3 million with you for 3 years instead of trying to get you a transplant at the very
At the earliest opportunity.
onset. So
Then that brings us to that conversation, because it's been there for a while, of how the NHIF should be revamped. There was a bill that went through the National Assembly, went through Senate, it passed, it has become law now, the NHIF Amended Act, right? Which was then supposed to have some regulations that bring that act to life. Just talking about enhancing how much we are paying in contribution as a percentage of income.
yes,
Talking about the kind of benefits that one gets. Talking about making it, what you just said, compulsory for everybody above 18. But this whole thing has never come to life. Where are we with these regulations?
2022, last year, January, that's when the act was enacted.
Yes.
And got presidential assent. Straight away, FKE, with others, Federation of Kenya Employers, went to court, and they are board members, and stopped the preparation of regulations in regard to matching contributions. You remember, it was to be that if you pay, say, if you pay 100, your employer was to pay 100 bob.
Yes.
So since then, under the guidance of His Excellency, he has decided to suspend that. We don't need that matching contribution and other things. So we have hammered an out-of-court settlement between ourselves and FKE, and we have prepared. I don't know why they stopped preparing the regulations, which were not hinged on what was in court because there was nothing stopping us. So now those regulations are being prepared as we talk. The public participation is going on now, and we hope that they will come to Parliament so that they can be approved, and then we roll out the act. You know, we start implementing the act as it was. Some of those things, for example, the change from hospital to insurance
To health.
meant that we can now empanel, say, laboratories, standalone laboratory, a standalone pharmacy, such that you can even run your what we call level 6 hospital without a pharmacy. If I go and find that somebody else is providing a cheaper medicine, we can go and buy there. The way the system is in UK, that you go to hospital, yet they don't stock medicine unless you are an inpatient. You go to a mall and get that. And laboratory is also like, I don't want to mention particular names, such that if you have a hospital, a government hospital, that does not have a lab that can perform certain
Say
tests.
MRI.
Say MRI, you go to, say, Hospital X in a county, they don't have it, they will send you to one of those facilities and it will be paid by NHIF. You come back, rather than the hospital telling you, the doctors are there, telling you, go and pay there and then come back. So that was intended to cure that. Yeah.
So you're saying the regulations are now under public participation.
Yes, public participation.
But the key one here is that the matching contribution by the employer
we have
is no longer going to be there.
the president has told us, forget it. It's bothering us. We've told NHIF, FKE as much. We've hammered an agreement they have not signed. I think the people who are supposed to sign are in Geneva. But regarding nothing stops us from
developing
the other regulations, and that was a problem. We should have done that before.
What's the main thing about those regulations? Apart from, so the contributions are now going to be pegged on gross income.
Yes,
2.7%, is it?
2.75.
2.75%
Yes.
of my income
Yes,
goes to NHIF.
to NHIF.
And the employer contributes zero.
Zero. But let me tell you why the 2.75. It was meant to bring equity. The people earning less than 35,000 were paying up to 5%. And the people earning, say, 100,000 were paying 1.7% of their income. So you pay 1,700, but somebody who is earning about 5,000 was paying up to 150, which was about 5% of their income. So all people below the scale of 5,000 were paying 35,000 were paying between 3 to 5%, while the others were paying less. So the idea now is to create a figure of 2.75. If you're earning $1 million, of course, that would mean you pay 27,500. There has been a very big debate, and that is part why we are having the public participation, meeting all these people and actuarists. And the idea is that probably we'll cap it at 50,000. So 5,000, 2.5% up to a maximum of 5,000.
Of 5,000,
which means you contribute about 60,000. The maximum contribution from a person,
60,000,
which is below the bracket, which you could go for private insurance. But we will provide certain all amenities. That means you can get treatment for that money. You'll be able to do a test, because the whole idea, once we get to the social health insurance, is to go even to prevention. NHIF kicks in to treat. But the whole idea is that we start with prevention. And that is why we have issues of community health promoters, about 100,000 spread out in all the country. all the county governments have provided government with the names of those 100,000 community health promoters. Before, there were community health volunteers, not paid. But now there is arrangements between the county governments. Yesterday, we were with the Council of Governors in Naivasha, and the minister, the CS for health, and the whole health sector met in Naivasha. And the discussion was about now the social health insurance and what we are going to do during the launch. The 100,000 spread out in what we are calling PCNs, primary health care networks, where everybody is taking care of about 100 families. So they follow you up. If you have a mother who is pregnant, they follow you up that you go for your antenatal clinics. They have thermometers. They have blood pressure machines, so that they start knowing you are likely to have, you are developing hypertension. Yeah. They have the gadget for measuring the blood sugar. So we capture the diseases and also advise people on lifestyle, how to live well so that you don't get some of these diseases. So it's a whole change. Yeah.
In the spectrum.
Yeah.
I know that makes City very happy because he's a very big promoter of that preventive and promotive health system.
It is indeed.
Let's take a break and then we continue the conversation at 7:30. Kenya's biggest conversation is hosting engineer Michael Kamau. He is the chairman of the National Health Insurance Fund. This is the anchor of what government is saying is going to be the universal health coverage. Now, we've had a start-stop with UHC. We've heard from the government that this year, by the fourth quarter of the year, we will be launching UHC in the country. So we have to look back and start wondering, is our anchor ready to actually carry UHC? That's why we have the chairman of NHIF here so he can answer our questions.
Spice.
Our conversation continues with NHIF chairman, engineer Michael Kamau, talking about anchoring the universal health coverage, a program that's been in government circles for a while, hoping that it's going to be launched later this year. NHIF must work and work well. And that's why you're talking about the regulations that are now undergoing public participation. Regulations are seeking to put that 2.75% contribution, capping it at 5,000, like you've said. But also, it's looking at reducing the minimum amount of contribution from 500 to 300.
Yes.
How does that help then?
Basically, it does. Because we'll be able to get in. Well, look at it. It was 500. There are people who are contributing less even before, like 150,000. Those people who are earning
150 bob.
5,000 bob. The idea is you get a guy, the voluntary contributors, even me, I'm paying 500,000. Is that 2.5% of my income? No. So once we get into these social health, the act is passed, we are supposed to find out what is your income. Relative.
Okay.
So with the community health promoters, we should be able to pick data on households and therefore determine whether if you just pay 300, 500, 600, so that it's not just the people in the formal sector whom we are squeezing. Let's say you own an industry and you make, you've just decided that your salary is 10,000. You can pick it, and the rest of it comes in terms of dividend. So how do we capture you? So that debate is out there. It's part of what we are discussing now, so that people pay their rightful percentage. Otherwise, we end up now, even you get an industrialist in the industrial area paying 300 bob. The same way they are paying now 500, which is the requirement if they're in the informal sector. Say somebody in Gikoba with a very big complex, it doesn't take any salary, or probably takes 20,000. It's not dependent on his it's dependent on his pay slip, but it's 500 bob because it is voluntary. But somebody who is in government, who is earning 5,000, is paying 5%. That's the whole idea of trying to come with a figure. And then we work out the mathematics of how much people should be paying. Yeah.
Okay. So now, obviously, there is still, even with that, huge responsibility on the shoulders of NHIF.
Yes.
Because it is the vehicle that will drive UHC. There's nothing else.
Nothing else at the moment. So
Right.
we are the ones who are going to do that.
Exactly.
Yeah.
Now, if we look at what mimics, or rather what would be the best idea to follow for what UHC could deliver, maybe we could look at the NHS in the UK, for example, whereby you walk into a medical facility, doesn't matter who you are, by virtue of the fact that you have contributed over time
Yes.
towards this, which now it's mandatory, it doesn't really matter, formal or informal. In order for you to get that number,
Yeah.
you contribute, right? So you walk into a medical facility, and really, from start to finish, whether it is opening up of a card, whether it is consultation with a medical practitioner, doctor, and then whether you need any kind of specialized treatment, whether you then need hospitalization because of surgery or hospitalization because of an emergency issue, it is covered from end to end.
Yes.
All you do is present your card. Are we saying today, because when we say universal, that's essentially what it means.
Yeah.
For everybody and through every process.
Yes.
Right?
Or inclusive.
All inclusive. From where you sit, would NHIF then be able, with the numbers that you've already talked about, contributing currently, would NHIF be able to deliver UHC? I'm not talking about the expectations.
Yes, yes.
I'm talking about ability
Yes.
today. And if not, what is necessary to take it now from where it is not to where it has to be?
There's a lot of work to be done. Number one is to ensure that the facilities exist, because you deliver health through facilities. So, and I told you we had a meeting with the Council of Governors yesterday, the whole ministry and people in the sector. One thing, there's a work that is going on visiting all facilities and making sure that if it is a dispensary, all of them are equipped to the same standards. That is it for the public sector. That a level 2 and a level 3 have the same, can carry out the same tests. Whether you are in Nakadok in Turkana, or you are in Vanga in Lamu, the two extreme corners opposite.
Vanga's in Kwale.
Vanga is in Kwale, yes, sorry. So, once we get that standardization, and that is being carried out by a team from Ministry of Health with others, then we can say that if you go to a level 2, this is what you get. One of the biggest problems that has existed is what we call self-referral. All of us ending up at Kenyatta or Bagathi with a cough. And what now we want to eliminate, no doctor will see you at Kenyatta if you appear there without a referral. If you go to Kenyatta or to Bagathi without having been referred by your primary institution, the one next to your house, or the one that you have picked, because you still must pick, because we are going to capitate the institution where you say you live. If you are in Buruburu and there is a clinic, a city council clinic that is there, you must go there. If you need further tests, they kick you up to a level 3 and then to a level 4. That's the only time they are going to see you. Now, what is the other issue? The other issue is for you now to get to Kenyatta or to get to a referral level 5 where you need surgery, complicated surgery. The government is going to start what we call a critical disease fund for cancers, for chronic, what they call chronic diseases, such that this now will supplement the insurance. So the government comes in with its own money for treatment of, say, kidney diseases, heart diseases, surgeries, and major surgeries. So that now comes in to support dialysis, such that the primary health care, all of it should be covered by NHIF up to level 4. As we get in up there, it is a combination of money from government okay? Which is consolidated. The government has so many schemes such that if they consolidated all this money together, we would be able...
you can cover a lot.
We can cover a lot. But right now you have disease for this, for tuberculosis, for that, for this. So if all that money was put together, we would be able to cover. The important thing here to note is that the experts have told us that the money spent for healthcare in Kenya is about 586 billion. So if that money...
Every year?
Every year. If that money still comes out of our pockets, and we have in excess of about 300 billion spent out of pocket, the money you pay for your, you go to your chemist, you get medicine, you go for this test. If all that money is consolidated, is about 300. If that money was to come to NHIF, then we would be able to sponsor all that treatment.
This is a very damning figure,
Yeah,
Chairman.
It is.
Because when you say that about 300 billion shillings is coming out of pocket.
Out of pocket.
For health.
Yeah.
This is close to the amount of money that's going for devolution.
Exactly.
Where health is anchored.
Yeah.
586 billion shillings annual health burden in the country every year is a lot of money.
It's a lot of money. Pick the money that goes to, say, Aga Khan, Nairobi Hospital. Pick all the major hospitals here. Their budgets and look at it. Okay? It's a lot of money. Pick all the people who are going to India. Include the cost of that air ticket and stay in India. People who are going and staying there for 3, 4, 5 months.
Yeah.
All the people going to UK. That's all out of pocket. Yeah.
And the whole idea here is that all this out of pocket, if you are paying a fraction of it into a contributory scheme like NHIF,
yes,
then it makes it easier.
It makes it easier
so
because
that we spend this out of pocket money should be less.
The young support the old.
Yes.
At 18, I'm not sick. At 20, I'm not sick. At 75, at 80, I'm having illnesses.
Yes.
So, but this guy who is 18 will support me, and when he gets to 20, he'll be supported. The healthy support the sick. So that's the whole idea of insurance. That's how they're able to pay claims. Even the whole, look at it, even private insurance. The reason why they are able to pay for
all the claims.
For claims is because you go for 1 year without Nini. They say, I can't remember the statistics we were told yesterday, that I don't know whether it's about 15% of the population that needs care. The rest doesn't. So that is why insurances make money, because they price their products, you pay, and they make profits. They don't get any other money from you. It's from premiums.
Engineer, the concept of pooling is proven beyond shadow of a doubt.
Yeah.
If it is, then I have to ask what plan NHIF has in looking at a very huge population, segment of our population, who fall in that category, school leavers, before they get to university. We talk about 1 million exiting, 1 million. Now, wherever they end up, whether they end up in some tertiary educational institution, whether they end up in university, these are people who at some point hope to be able to earn a living, whether through employment or self-employment. What does NHIF do to ensure that this population is adequately educated to the point where they understand these benefits, so that early in their lives, this is something that becomes a natural part of what they do? Because every year we have this group of people coming in. Every single year. It's a large population. And these are the people who don't fall sick regularly.
Yeah.
They are young. And they have decades before they fall into that category. So these are decades of contribution that would be enormously helpful.
Well, number one, that is an issue that we need to tackle. First of all, they don't have an income.
Yes.
Therefore, they are not able to pay. That is one of the problems that we have. But we allow parents to sponsor. They can have sponsors. That means the primary contributor, if you are in college at 24, up to the age of 24. If you are in college and we have proved that you are in college, Then you have a sponsor, a parent,
Or a guardian. Or
a guardian.
Can I suggest something?
Yes.
Some of these things can be inbuilt. If somebody is in a tertiary college, fees is paid.
Yes.
Is it not?
Yes.
Some get government capitation. Do they not?
Yeah.
Yes, they do.
Precisely.
Oh, in that case, I spoke about Eduafia.
Yes.
For example,
Yes.
where the government is
Yes.
covering all students
Yes.
in
Public schools.
Public schools.
Yes.
We also have programs for indigents,
Yes.
where the county governments, with their people, register people who are unable to pay. The elderly, people without an income, and those are some of our programs for indigents, elderly, and orphaned,
And disability.
and
Yes.
people with disability.
The majority of our population don't fall into this category.
They don't.
These are minorities.
Yeah.
So they've already been taken care of. Adequate thought being given to this huge population, and they increase every year. We have these people. It cannot be that because they do not have a job or employment, they cannot pay. No. A way must be found so that they are part of this contribution.
Part of it, and part of the discussion that is going on now, is that to enable people to get loans. You see, like the idea of the hustler fund, where people can get loans and pay upfront. If it is the 300 bob, it is 1,800. You get a system where you are able to pay the 1,800. That is for 12 months. And then when your income comes, because the discussion was, and somebody gave it a very funny name, you're having in January it is 000, then you have 10,000, then you have 5, then 10, then 20. Okay? So if we put systems such that you are able to get what we call, there's a name they use, premium financing for healthcare, then you can pick a loan at the beginning of the year. Say you are supposed to pay 500, that is 6,000 bob. Pay that 6,000 bob, and when your income comes in, then you are able to pay such that you remain covered. So there are several ways, and there is a lot of thought that is going into what you are saying.
A lot more needs to go into it because it plays into what you call a savings culture. Developed nations that are able to have the sort of money that they can then lend to poor third world banana republics like ours comes from the savings of their citizens. It is something that we have to deliberately inculcate in young people, that you don't have to have a lot of money to be able to save money.
Yeah.
What you need is the discipline to save money. I am simply saying that these cultures we keep talking about, these difficult things, we inculcate them early. This generation is the so-called future of our nation.
It is.
We need them to be thinking differently from us. We need them to be doing things which are different from us. We need them to be doing things that will help them more than our thinking has helped us.
And I think that is exactly what the Hustler Fund is doing.
Is it?
Yes. You borrow, and a part of what you borrow goes into savings. I don't have the figures here, but the idea is that
2.5.
It's 2.5% of what you borrow. So, and I think the savings have gone up to in excess of several billions.
Yes.
For the people who have been borrowing.
Can that same thing also go into paying for healthcare? Because what I'm trying to say is the ways in which this can be done exist.
Yeah, they do.
And if they don't, what stops us from creating these things so that it actually happens? It's too large a group to be ignored.
Yeah.
In fact, this radio talk is a public participation. And that is why I pick ideas from you.
I want to ask a question about equipping.
Yes.
The vital issue, one of the vital issues that you've mentioned here is, look, if you can get people to stop going to your referral hospitals for a cough, as you mentioned,
Yes.
and visit your local dispensary first, and then you start going up the levels to clinic, to 1, 2, 3, like that. One of the issues that has been had before is with equipment infrastructure. Not has had, is a present issue.
Yes.
So, and we're talking about things like water. We're talking about electricity.
Yeah.
We're talking about
A tablet.
seriously, aspirin.
Yeah.
You know, and that's an issue. These are the reasons why I just looking at reading, is that people are not going to these dispensaries because they want to travel far. Nobody wants to get up in the morning and travel kilometers to a facility and skip the one that's next to them. but the one that's next to them does not have what is necessary to even treat them. That's why we have people showing up for a cut and things like this. Now, how would NHIF work with the equipment? I mean, just today we've seen that they want to put more money towards the managed equipment services, where we know that those have not been functioning properly for the last few years with all the scandals that have been around that. What would be done to make sure that infrastructure is equipped adequately, because it is a major part of this? If there's a dispensary next to you, or if there's a level 2 hospital next to you where there's no water, that's a big problem.
Yes.
If you have a radiology machine where there's no radiologist, that's a problem. Medical practitioners are asking to be hired. So all of these things work hand in hand. I would see it almost, shackling NHIF
Yes.
to say that you are the driver of this thing. But then there are 1,000 other things that need to be done. And we're going to turn around and blame NHIF when UHC doesn't work, when there are many things that also need to work at the same time.
Actually, the out-of-pocket expenses included what you have just alluded to, transport. That the facility outside your door doesn't have the equipment, and therefore you are going 20 kilometers away.
Yeah.
It's a major cost, even in terms of time. Let's start, let's say, bottom up. Let's start with the community health promoters. They are being equipped with a kit, a backpack, which has a tablet that has the app. Just for that, it cannot be used for any other purpose, and which will be paid for in terms of data, thermometer. I said a BP machine. There will be a blood sugar machine and several other gadgets that help you, and of course records. It's quite a pack. Then I mentioned that under the Ministry of Health there is a team that is going round to make sure that the level 2 facilities are standardized. If it is level 2, you get this kind of equipment. It is not over-equipped, but it is properly equipped. Level 3 and level 4. So a lot of work has to be done, especially for the government institutions. Government institutions. One of the things that the president has pronounced himself on is that devolution, health is a devolved function, and there is no attempt by the government to crow back on any of that or part of that. So the government is going to support the national government is going to support the county government in improving the facilities. Can I tell you one of the problems? One of the biggest problems, in fact, we have enough money.
In Kenya.
Even within government and NHIF. And I'll give you the best example. There's something called Facility Improvement Fund.
Yes.
Which is supposed to be passed at the county governments. Okay? Such that all money coming, referred from NHIF, is ring-fenced within the health sector. It doesn't leave the health sector. It doesn't go to buy fuel or arrange for a meeting somewhere, a Kamukuji, or buy an air ticket for
the doctor.
For the doctor. Believe it or not, Nakuru is the top county government. All the money we pay out for the health services, reimbursement, 70% goes to government facilities in Nakuru. They have, and we have said everybody should go and benchmark there. Now, 27...
Which means that many people in Nakuru are preferring to go to a public health facility.
Because they get the services. But what is it? What has Nakuru done? And this is where the governors should bite the bullet. The same surgeon who treats you at the county government is the same surgeon who does the operation at a private hospital. So what Nakuru did, on top of ring-fencing that money, they made sure that they have performance contracts with the doctors such that if you are supposed to perform 3 operations per day, you perform them. You perform your 3 operations, then you can be left to go and rest. Now you can go and do other things. But even if we ring fence the money and you do not have performance contracts with your medical staff, they will not be available. So Nakuru is the best example. Now, what we agreed yesterday, because I was in that meeting, is that the 22 counties that have not yet passed the Facility Improvement Fund are going to do it within the next 2 months. And the governors are willing, not only willing, but they have seen the benefits of ring-fencing that money, because healthcare is one of the biggest deliverables for governors.
For devolution.
Yeah, devolution.
And it also gobbles up the
So
largest amount.
Now,
from
the other
budget.
problem, now let me mention another problem. Failure to claim. The governors do not equip their facilities with gadgets to claim. So you find, like in one particular county, they have 65 health centers, but only 2 are making claims.
To
So
NHIF.
to NHIF. So the governor keeps on pumping. They are pumping the money. They are not getting reimbursements. So they should be very smart, like the private hospitals, where they make claims to NHIF on a daily basis.
Yeah.
We have one county that stays for 6 months without making claims. Then, of course, they drain all their resources. And when you go there, the reagents are not there.
That's true.
So there's a lot of work to be done, as you said.
Like we say, Bwana Chairman, as we gear up towards the launch of universal health coverage, we'll want you to keep coming here more and more, and come with your officers so we can understand NHIF and all be in that bus as you get there.
In fact, I would be very happy if you invited our CEO.
We will.
Yeah.
We will do that.
Dr. Kuhora, acting CEO.
Engineer Michael Kamau is the chairman of the NHIF board. He's been our guest. Keep it here for more conversation.
This is the Situation Room, the only way to start your